Let's take a question from the studio audience. Hi, go ahead.
Hi, I have another question for Bev. You demonstrated unilateral patterns in chopping and lifting. What value, if any, do other combinations of movement have with a neurological patient?
Okay, that's a good question, too. The other combinations, we've demonstrated bilateral symmetrical, we demonstrated bilateral asymmetrical. The other combination of the upper extremity is bilateral reciprocal, where one arm is in flexion and the other arm is in extension, and then they would switch. And I found that that has been valuable in working with patients who are in later stages of recovery of hemiplegia, where there might be some residual weakness in the scapula that wouldn't show up in the other patterns. But when you start doing the more complex pattern of reciprocals, that scapular instability comes out, and I can begin to then resist the reciprocal movements and develop some more control in the scapula and the upper trunk.
Let's take a phone question. Hello, you're on the air. Where are you calling from?
I'm calling from Gary, Indiana.
Welcome to the video conference. Go ahead.
I would like to ask either one of the therapists if it's necessary for the patient to be able to understand and follow commands to benefit from the PNF techniques.
Greg, would you like to lead?
Yeah, I'll start on that. It always helps. I think that we all know that, and but there is a lot of times that we have aphasic patients, and you'll see a little later Evia, who we've seen also so far, does definitely have some difficulty in being able to understand the commands that I give her, but yet through the manual contacts, the stretch reflex, and the other techniques that we use, we can often stimulate a patient to do it. At Kaiser, frequently we would work with people in comatose conditions and still be able to get some significant improvement in their motor patterns, not necessarily volitional, but through use of stretch and through use of other things that could get active contractions. And so I think that you can definitely treat someone. It makes it more difficult than in those cases. Did you have something you wanted to?
I just wanted to share a couple of examples. In one of the courses that we were doing, one of the patients that they brought in for demonstration was legally blind. He was deaf, and he also had ataxia quite severely. And I was glad I wasn't the person who had to demonstrate with him, but it was interesting to watch what the therapist did. She put him down into a side-lying position, which was the most stable posture to begin with, and then did rhythmic stabilization with one hand on the head and one hand on the end of the spine. And just through the tactile cues and the pressure, that patient was able to hold in that position. And so he couldn't hear anything and he couldn't see anything, and yet he was able to respond. And I asked that therapist afterwards what gave her the confidence to be able to do that. And she said that she learned to do that because she had taken her dog to obedience training in school, and he was not very cooperative. And they were supposed to stand and hold this sitting position for periods of time. And when the instructor went down the road to check, when he wasn't looking, she would approximate and stabilize her dog's shoulders just to make sure he'd stay there, and then come back after the instructor would pass her by. And that worked for her dog, so she knew that it would work for this patient.
Let's take another call. Hello, you're on the air. Where are you calling from?
I'm calling from Grant Hospital in Chicago.
Welcome to the video.
And my question is for Beverly.
Go ahead.
What effect does PNF have on shoulder, wrist pain, and hand edema in the hemi patients?
That's a good question, and I think PNF is very valuable in working with patients who have shoulder pain. We're going to be seeing a video clip later on of a patient who has shoulder pain, and perhaps the PNF technique that's most valuable is the approach, the indirect approach, and being able to lead from strength. And the hemiplegic patient has other areas that you can resist, that you can work with, that will influence the painful shoulder. So you can use the lower extremities, lower trunk rotation, bridging, working with the unaffected arm and to get some irradiation down to the affected arm. You can also put two hands together in the chopping and lifting pattern to facilitate some rotation to get some more input to that shoulder. And I think working in the diagonal patterns, just being able to elevate the arm, say in diagonal 2, and be able to do a grasp and release activity as you're going through the whole pattern rather than just on the table surface will help to facilitate a decrease in that edema, and the patient can carry that over at home for himself.
Okay. Did you want to add something, Greg?
Yeah, I would. On the area of pain, I think it's really important to know that within PNF, our whole principle is related to the fact that you don't increase pain with anything that you do. So you always work with the patient to try to monitor within the level of what they have pain in. But you can always function in those ranges of motion that are non-painful and allow them to start gaining strength and range of motion and everything else there. But the emphasis has to be don't duplicate, don't cause any pain, because the minute you do, you change the whole picture.
Okay. Those are all the questions that we're going to be able to take right now, but there will be another Q&A segment at the end of the program, so keep calling in your questions and comments for Greg and Beverly. Let's turn now to the techniques of PNF. Bev, how do the techniques relate to the total patterns and the diagonal patterns?
Okay, all the techniques in PNF are superimposed on the total patterns of movement and posture. So we would be using the techniques are most effective when done in total patterns and diagonal patterns.
Okay. Greg, how would you summarize the use of PNF techniques?
Okay. I think that the PNF techniques are the most important tool that we have to be able to alter movement patterns. Everything is evaluation, as we said earlier in PNF, until the time you find a dysfunction. Then you can choose your appropriate tool or technique to help facilitate an improvement in that function. And then you only use that technique until the time that you've started getting volitional or habitual activity in that individual. Then you start weaning it away and start taking it away so that that individual now has independent function.
Okay. Now what we'll do is ask you both to show us some PNF techniques. We'll be looking at the ones on pages 10 and 11 in the workbook, just FYI. Greg, we'll ask you to go first, and you can start whenever you're ready at the table here.
Great, I'm ready. If Julia, please come out and let's get started.
As you go, we'll mention that there's no truth to the rumor that the Aaron logo was designed to show you what diagonal 2 flexion is all about.
Could you lie on your side, please? Okay. If you'll turn to your notebooks, under techniques, and you'll start, and it's after the diagonal pattern section. You got that page? The first one in there is combination of isotonics. Now this is a technique that actually I defined. It's one that I think that we've always used, but it's just a definition of it. It's a very important technique, I think, and I use it a lot because we're able to evaluate isotonic contractions, concentric, eccentric, and maintained. Through that, be able to evaluate how any individual movement pattern is able to perform these three motions, and then be able to come back and do very specific type of treatment to improve it. So I'm going to start with Julie's pelvis. Just get into a position, and I'll perform a combination of isotonic first, just as a means to be able to evaluate how she performs the three contractions. Shrug up, concentric, good concentric contraction, maintained, particularly if it was a postural muscle, and then eccentric, letting it go slowly while I'm still pulling her down. In each one of these phases, Julie performs it very well. Pull up, shrug up, keep it, let it go slowly. But let's just use an example here to say that she might have difficulty being able to get to the end of the range of motion. And so what my goal is for her to be able to reach a target, but she doesn't really work within the pattern, let's say. So I'm just going to have Julie pull more up and just go part way through the range. And if she only goes that far, then I know she's got limited range of motion and she doesn't know exactly where I want her to go. So I can immediately use a combination of isotonic by first starting out with the maintain contraction right at the point where I really want her to be able to go, and have her keep it here. Let her go slowly, just a little bit, but just a little ways eccentric, and then back up with the concentric contraction back up to the target position. Have her keep it here again. Slowly let it go so she goes further through the range, and shrug up further back up to that position. And let it go even further, and now shrug up. Great. Let's use one more example, and that would be during the eccentric phase if she's having a lot of ratchety movement, is that I could have her have it in the maintained position, hold it. Then as she slowly lets it go, she may get some ratchety movement here, and then I'd immediately have her go into a maintained contraction. Keep it here, don't let me move you. Shrug up just a little bit, and now come back down slowly. There, and she'd slowly start learning that feeling of being able to switch from the concentric to eccentric to maintain, which is the normal way that we function in everyday life. Let me use one more example before we go to a videotape, and that would be coming to standing. So I'd have her come up and be in this position, and in combination of isotonics, how essentially I'd work with it here is that she would be in this position. The concentric contraction would be as she comes up to standing, and I'd resist it. The maintained would be in the upright position with approximation. And then the eccentric, that controlled eccentric contraction and going back down to sitting. And Julie, again, has good control of all three of those. Okay, at this point, I'd like to go to a videotape so that we can see it actually being done on Evia. Now I'm going to see how she does with a combination of isotonics. Keep your pelvis up here, Evia. Don't let me pull it down. Keep it right there. That's it. Real hard. Now let it go just a little bit and pull back up again. That's it. Now pull again. Good. Now pull again. Excellent. And pull again, way up. Very good. That was a very quick section, but I think you could see how effective and how quickly she learned that motion. The next one is going to be more for those type of rigid patients or patients who have difficulty initiating motion, those who have complication in being able to set up a rhythm in their motion. A lot of times we'll see this in our Parkinson patients, as an example. And the technique is called rhythmic initiation. It has three basic components to it: a passive phase, an active phase, and a resistive phase. In each one of these, you're able to evaluate how well the patient can allow you to move impassively, how well they can do an active contraction, and then how well they can take resistance. Within this inherent is a basic timing or a rhythm that's set up. And so I'm going to begin with Julie on just taking her with a lower extremity pattern of flexion adduction with pelvis anterior elevation timed together, which would be the gait pattern. And at first I'd ask Julie just to let me do it passively with her. Let me move it very slowly through the range of motion. And notice I set up a rhythm that's a very set timing so that it's the same rhythm. If she's having difficulty letting go and relaxing, then I try to do some techniques to help her let go a little bit more. Then as I'd work through it further, I'd start asking her as she lets go and she relaxes enough to just start pulling herself and let her pull up without resistance so that I can monitor how well she's able to actively contract the leg with the pelvis and how the lower trunk actually comes in, as you can see the lower trunk rotation that's occurring. And then I'd go into resistive. Now pull again. Good. Now pull again. Good. And now pull again. The same kind of technique can be taken through all different functional activities, particularly, let's say, gait, in which you can take someone and actually work with them and going through rhythmically, in which you guide them through a motion so that they learn how to initiate and how to perpetuate a rhythmic motion. You can also take it in by using of canes. A lot of times by having the patient hold the cane while you're working with him, you can start helping them with their upper extremity movement while they go into gait. We've got a videotape section also on rhythmic initiation. So let's go ahead and take a look at George with use with upper extremity. Now let's take a look and see, George, how well you can do on this side. So bring the left arm back. Okay, having some difficulty being able to get the arm to come back. So let's actually start doing some work which might help him. So first of all, I'm just going to start with almost a rhythmic initiation, started out with stretch. You can see how that helps his arm to come back. So a lot of his problem may actually come from the scapular retractors that he needs to be able to get that scapula moving there from. And actually look your head towards the arm as it goes back, George. Follow it back there. Good. Follow it back. Do you get a feeling for that? Good.
Another technique that you can use is hold, relax, active movement. And this would be done for a patient who has had difficulty initiating the movement from the lengthened range, or probably a lack of endurance to complete the full range of motion, or perhaps an imbalance where the antagonistic muscle groups are stronger than the agonist. For example, the patient who's trying to roll might have difficulty initiating the movement. Go ahead and try and roll over. and might just get that far but not be able to complete the motion. So what I would do would bring Julie all the way over to the shortened range of rolling and just get an isometric hold here. Hold it there, a nice strong one, and then I would have the patient now let go, and I would pull them back quickly to the lengthened range and now roll over and ask them to return the response. And I would repeat this to build up some strength. Hold it there, and now let go, and roll back over. That's it, and hold it there, and let go, and now roll over again. And this I tried on an incomplete quad. Was a patient that I had, and I went and pulled the patient all the way back to the lengthened range and asked him to roll, and you know what happened? Nothing. And I went, is this technique working? And so what I had to do was to then just bring him back through partial range towards the lengthened range. So when I had him hold there, hold it, and now let go. Just brought him back a little bit. Now roll back over. That's it. Hold it there and let go. Pulling him back a little further each time. Now pull back over. That's it. And hold it there. And then the next time I could pull him all the way over. Now roll all the way over. And he was able to complete the motion. So this technique is a good one to begin to get started, but really repeated contractions places an increased demand and is better for strengthening of the patient. And Greg is going to be able to demonstrate that now.
Great. Julie, could I ask you to come back up here, please? You keep bouncing back and forth. You're a very busy lady today. Could you lie with your head up here, please? We're going to do it on your upper extremity pattern. And lift the table up. Okay, now, repeated contractions. We've already presented the stretch reflex, in which we identified that the stretch reflex is something that we can utilize to facilitate a contraction. Now, we also know that we can take that stretch reflex and superimpose it upon a contraction. So we're going to have two basic ways that we're going to use repeated contractions: by using repeated stretch either to initiate a motion repeatedly, so you set up the timing, or to superimpose it upon an existing contraction. So first of all, let's just get an idea of that stretch reflex, and I'd like to demonstrate again how the stretch reflex occurs better in pattern than it does out of pattern. First of all, I'm just going to go ahead and set off a stretch reflex with her in pattern so you can see the response, and then I'm going to do it when she's not quite in pattern with too much rotation, and you might be able to see a change. So here in this position, I give her a stretch, and you can see that there's a pretty good rebound there, that she comes up and back from the stretch. Now watch, if I just take and rotate her hand a little bit more this way, watch the difference in that stretch. You see how she's not able to get a good stretch there? If I move it a little bit more out of pattern here, there's really no ability to do it. But the minute I get into that place where the pattern exists, you automatically get your stretch reflex. So that's how I know where I'm at. Now, repeated contractions in this position would be to help somebody initiate it, to assist them in beginning to get increased strength, and to improve their endurance so that you decrease their fatigue, because the stretch reflex helps to keep fatigue down and helps to facilitate the contraction. So lift up, good. Lift again, good. So I'm going to the beginning of range, repeating that stretch, using my body mechanics, my body position to assist this motion along with manual contacts. Now, if I wanted to switch that to do it through the range, I do a stretch, and then as we go through the range, add a repeated stretch repeatedly upon the pre-existing contraction. So there's nothing Julie has to do but continue to push at me, and I'm just setting up a stretch, and this would be especially effective in someone who gets weak partway through the range or who starts losing the direction that they want to function in. We've got a videotape for this that we'd like to move to at this point so that you can see it. She's really not initiating the motion real well, so I'm using some stretch reflex just to help her. Some repeated contractions. Pull up again. There she's going. Now she's starting to get that motion. Beautiful. Pull again. Good. Pull again. Excellent.
The next technique we're going to take a look at is slow reversal and slow reversal hold. And we're going to be looking at some techniques that use a reversal of antagonists. And why is reversing so important? It's because of function. You really can't feed yourself unless you can reverse your hand to get down to the plate to get some more food. And you need to be constantly working on reversal of movement with patients, especially the hemiplegic patient. So the slow reversal is just simply an isotonic contraction that we can resist. I would ask Julie to close your hand turn and pull down and across, and then resist the antagonist and come up and just smoothly pull down and across. The antagonist and then the agonist. Usually you're going to be doing this to pull down and across and lift up and out. To teach them how to get a more rhythmical movement for reversing direction. This can also be used to help to strengthen the response of the agonist. For example, if Julie was weak in the D2 flexion pattern, I might begin, let's just test that out too. I want you to open your hand and bring it up to me. And I'm just going to ask you to hold it there. Hold it. Okay, and now I'm just going to resist the antagonistic motion, pull down and across. Isotonically, go ahead and pull it all the way down and follow it with an isometric hold at the end. Hold it there. And now just putting my hand on top, no resistance, open your hand and bring it back to me. And we'll test it again. And hold it there. Hold it. And she's much stronger. Can you feel the difference? Mm-hmm. Okay. And so you can use a slow reversal hold to increase the response of the agonist via the principle of successive induction. We're going to move on now to another technique of reversals called rhythmic stabilization. I'd like to just have you lay down with your head here on the side. And rhythmic stabilization, I think, as an occupational therapist, has been the most valuable technique for me. For I've been able to use it before activity to help get the patient more stable, during activity when the patient fatigues, and after activity to get a more balanced response before they leave the clinic. And so I just like to demonstrate that in a side-lying position. Some of the factors in doing rhythmic stabilization that need to be adhered to is that your patient is in a stable position. And so if we had a pillow, it would probably be more ideal. And we also want to make sure that her lower extremities are stable, either together or even moving the one forward on the mat, and make sure that it's comfortably in touch with the surface, as is her hand. I need to be in a stable position as well, otherwise I'll give the patient some cues to move. And you're going to be placing your manual contacts on both surfaces because rhythmic stabilization is a simultaneous isometric contraction of antagonists to help promote stability. And I'll just demonstrate what it looks like, and then I'll explain a little bit further. Just want you to hold, Julie. The verbal command is to hold, and I'm going to just approximate down through the pelvis and the shoulder girdle, and now hold it. And I'm resisting the rotation in the trunk at the pelvis and the scapula. And hold. And hold. And relax. So you can see if the manual contacts do need to move to get a better position on the patient, that you want to keep them in contact with the body and just slide them along the body, such as we call it slobbering the input. We have a rhythmic stabilization is also can be done at really any part of the body, any joint, and we just have a videotape now of two different ways of using rhythmic stabilization on the trunk and also on the shoulder girdle. Let's take a look at that tape now. And Francis, what I'd just like you to do is to hold this position, and I'm going to just do some rhythmic stabilization. So just ready? Starting with the strong shoulder and the right hip first, and hold it. Working indirectly proximal to distal, getting some stabilization through the trunk first. And hold before we move more directly to the affected shoulder. And relax. And now I'm going to switch to the other side and the opposite hip. Ready? I'm not going to do as much approximation on this side because of the near the pain site, but I am going to approximate the hip. And hold it there with light resistance on the shoulder and much more resistance on the hip. And hold it. That's it. And hold. And relax. And just hold it there. Don't let me move it. Hold it. Good. And hold. Just giving some rhythmic stabilization to scapula and shoulder. And hold it. And relax. last technique we want to take a look at is one for relaxation. There are other techniques for relaxation that you probably have heard of: contract, relax, and hold, relax, slow reversal, hold, relax, active movement. But we felt for the purposes of this video conference that the most valuable technique for relaxation with a patient who has neurological dysfunction is rhythmic rotation. And rhythmic rotation can be done either voluntarily or passively. And essentially all it is just a slow rhythmical rotation within the diagonal pattern. And I'm going to have Julie demonstrate it to you first as it's done actively. And if the patient has some tightness or in the lower extremities, we might begin by just having the patient rotate their toes inward and then outward. I want you to just, you can passively take them through it, just rotating them in and then bringing them up and out. And go ahead and do that. You can have them do it slowly though. Always teach the patient to do it slowly, and you might do it 2 or 3 times and then have them spread their legs apart a little further and try it again. That's it. A couple more times. And then even further so that you can get as much abduction as possible while you're doing the rotation. That's it, a few more times. So you can teach the patients to do this themselves. If they're unable to carry over with this, then you can do it passively. For example, just holding underneath the knee and the heel and beginning to just rotate in the diagonal pattern. And I'm using my body to get the rotation, and we need to remember that because legs are heavy. And if you use your body, then you won't feel that you're doing so much cranking with your arm. You want to try and get the rotation occurring in the upper leg as well as the lower leg, and not one, rotating further than the other. So this is very smooth and rhythmical, and you can do it for a long period of time. You know you've done it probably long enough when you begin to feel it in your quads. And then as you feel it loosening up some more, you can move the leg out into further abduction and repeat it again. And just continue slowly rotating the extremity. We have a videotape of this with a patient who has hemiplegia and some tightness in the shoulder. Let's take a look at that now. Another technique we could do at this point might be some rhythmic rotation. I'm just going to slowly rotate Frank's arm at the point where I felt some tightness, using my whole body to get the rotation, not just cranking my arms. Getting rotation at the shoulder as well as at the forearm. This is a technique that can be effective with very spastic patients, as well as with those who just have minimal spasticity. It's helpful prior to doing ADL, such as lower extremity dressing, being able to loosen up the hand in order to do some hygiene, or loosening up the shoulder to get in and wash the armpit. And as I feel it loosening up some more, I can move it back a little bit further and repeat it again.
Time now for our second break, and that's a good time to call in your questions because our second question and answer segment is not all that far away. The number to call toll-free, 412-621-7161, and we do advise you to get your questions in as early as possible, and when we go into the Q&A, we'll take just as many questions as we possibly can. We'll see you in 15 minutes. welcome back for the third and final segment of PNF for the Physical and Occupational Therapist. Let's look now at evaluation. Bev, how would you begin a PNF evaluation?
Well, I think I'd like to make one comment about evaluation and using the PNF approach.
Yeah.
It should not be considered a replacement for the formal evaluations of range of motion and manual muscle testing. Those are still necessary for the patient. But I think to recognize that the PNF evaluation will give the information about function that you might not get from those other evaluations, because they show how to put combinations in different muscle groups together. And one of the ways we can begin to evaluate a patient is to follow the cephalocaudal direction of development and look at the movements of the head and neck and the vital and related functions. And I believe we have a videotape.
We do indeed, featuring the first part of your evaluation of a patient named Kurt. Can you tell us a little bit about him?
Yes. Kurt had a head injury 4 years ago, and he's about 20 years old.
Okay, then let's take a look at the first part of Bev's evaluation of Kurt.
In PNF, one of the principles is to follow a cephalocaudal direction of development. And we follow that principle in evaluation as well, beginning with the head and neck and the vital and related functions. And so Kurt has come today so that we might demonstrate how we might begin an evaluation, starting with the head and neck and the vital and related functions. So Kurt, just to start out, I'd like to have you, Kurt has had a head injury 4 years ago, and he's currently in school now and will be graduating this June. So Kurt, just like to have you show them how you can turn your head from one side to the other. Good, and now to the other side. Okay, a little more rotation on the right side. Now I'd like to have you take a look down at your left hip and then up over your opposite shoulder. Look way back there at the door. That's it. And back down again at your left hip and up over at that door there. Okay, and let's see how that compares with the other side. Looking down towards your right hip and up and over the other side. And down to your right hip and up and over your other side. Extension is a little bit less going towards the left side as well. So let's just try doing some breathing together. And I'm just going to place my hands on, one hand on the sternum, one hand on the dorsum of the upper spine, and just going to follow through his movements. I'd like you to take a breath and blow it all out. That's it. And breathe in again. When you breathe in, can you put your lips together? And then blow out through your mouth. That's it. And I'm just going to stretch them a little bit and breathe in. And blow it all out. Good. And breathe in and hold it. Now breathe in some more. And some more. Oh, and blow it all out. Another area that we can take a look at is the, I want you to turn your face and look right forward there, is to take a look at the nasalis and the procerus muscles in the nose. And why would we want to take a look at the muscles in the nose for this particular patient? Sometimes in breathing, there might be a nasal passage that needs to be freed up from some blockage, and some resistive work with the nose, muscles of the nose can help free that up. Also, you look for the reinforcement. All the muscles in the face can reinforce each other, and the nose muscles can reinforce some of the movement in the upper lip. Okay, Kurt, I want you to bring your lips together. That's it. Hold them there. Good. And smile wide. Now do it again. Bring them together. Hold it there. Now bring them together some more. That's it. Bring them together some more. Good. Hold it there. And relax. Okay, lip closure also occurs in a vertical motion of pressing your lips together like this. Can you do that, Kurt? Bring your lips together. Very deliberate action. So let's try a little resistance and see how that affects it. Okay, open your mouth. That's it. Now, bring your lips together and hold it there, resisting the upper and lower lip and open. Okay, and bring your lips together, hold it, bring them closer together, that's it. Get them touching and hold it there and relax. Good. Now open your mouth again for me. And now bring your lips together. Press them together. A little bit faster reaction, a little tighter response. Okay, one other muscle we might take a look at in the mouth is the buccinator for compressing the cheeks. This muscle is important for patients that have a problem pocketing their food. And let's just see how Chris's buccinator looks. I'm just going to put my fingers in your mouth and stretch the muscle inside your cheek. Okay, so open your mouth and just bring them together like this. And hold it. That's it. Bring them in some more. That's it. Bring them in some more. And some more. Hold it. And relax. And not as smooth a response to resistance. So let's just try it one more time. Okay? And just want you to now bring your cheeks in. Good. Hold it there. Bring them in some more. Get them in some more. And hold it. And relax. And now looking at the coordination of the tongue, see if you can move your tongue side to side real quickly. Can you do that? Coming from side to side and look straight ahead. That's it. And keep moving your tongue from side to side. Fast as you can. Okay. And relax. Another part of evaluation in terms of looking at active movement and resistance is also to look at adjuncts. For example, icing, and what kind of effect icing might have on the movements to determine whether you would want to include that in your treatment. So I'm just going to take a look at with an ice tub, and just ask Kurt to open your mouth. I'm just going to ice the inside on top of the tongue. That's it, and under the tongue, and relax. Okay? Go ahead and swallow again. Okay. And looking straight ahead. Now, Kurt, I'd like you to try that with your tongue. Same thing again. Move it from side to side as fast as you can. A little quicker response just based on the ice. And so it looks like the adjunct of ice would be an important one to include in treatment.
Bev, where do you go from here after the initial stages of the evaluation?
Okay, with Kurt, I probably would begin with, while he's in the chair, just looking at some of the upper extremity patterns and combinations. And then probably would have taken him down to a mat to begin to look at his ability to assume and maintain and possibly move in different total patterns. Would be looking for what patterns might be deficient, if there are any imbalances, and maybe trying some techniques to see if any made any difference. Also looking at what was needed more, mobility or stability, so I could begin to get a place to begin starting treatment with him. Another thing I would take a look at then is observing observing him in functional activities, such as getting out of bed, getting up and down from the toilet, getting dressed, etc., and see if there are any discrepancies in what he was doing functionally versus the abilities that I had seen him perform on the mat. For example, if a patient would be able to do the diagonal pattern in rolling on a mat, but wasn't able to change their position in bed, I would want to know why and try to analyze and see if I could put together some combinations to facilitate that. And then I would also want to know from the patient what his goals are. And I know with Kurt, one of the questions we asked him was if there's any one thing that you would like to do now that you're having trouble with, what would you like to be able to do? And his answer was he wanted to walk in his graduation, which was occurring this June. And so I know that all the techniques, and even though they seemed to be effective, of oral facilitation and being able to work on the facial musculature, probably weren't going to be as important to him as what he was maybe doing in physical therapy. Another patient I had asked that same question to, and she was a patient who had some limited range of motion in her shoulder. And right away I'm thinking, okay, how can I increase, the flexion using diagonal 1 flexion, using diagonal 2 flexion patterns? And I stopped and asked her, what is the most important goal to you? And she said was to be able to wipe herself after toileting, which is the complete reversal of the direction that I was going to emphasize. So I think that's always an important aspect to include in the evaluation.
Okay. So we've reviewed evaluation, and before that we talked about total patterns, diagonal patterns, and techniques. Now the big question, and it's at least $64,000, how do we put all of this together in treatment? What we'd like to ask you to do now is to give us one or two key concepts for treating each of several different types of patients. And Greg, let's start with you and ask you about two ends of the continuum, patients with ataxia and patients with rigidity. How can PNF help?
Okay, this is a good subject to kind of go into and actually start into this section with, I think. Of course, every patient differs, so you can't use this as a cookbook to approach them, but more as tools in which we can approach each patient with. When we're dealing with this continuum, we'd see that there's a continuum of a postural tone that exists. It's from one end where you have the flaccid patient and the ataxic patient. Certain pure ataxic patients would fit down at that end of the spectrum. The opposite end of the spectrum is the very rigid patient, or like the Parkinson patients. So we have two opposite end of the scales here that we can maybe compare and contrast during this section to talk about maybe a way that we can both view them and evaluate them, and also how to approach their treatment. So first of all, I think we'd have to start with proximal stability. As far as the ataxic patient goes, they lack proximal stability. They can't hold on to their scapulas, their pelvis, their spinal musculature. Each one of those areas where the tone should be there when they need to be in a stable position, they lack the ability to maintain that contraction. On the opposite end of the spectrum, the Parkinson patient, he can't let go of that, and therefore he can't move. He's lost the ability to move. He's somebody we work more with rhythmic initiation to try to stimulate that movement, where the ataxic patient, we're going to work more with stabilizing and holding contractions. The ataxic patient has difficulty with initiating contractions, but their initiation is one that is an excessive one very frequently. They overshoot their goals. They start out in a very forceful contraction, and they can't grade their contractions when they begin. Where the Parkinson patient has real difficulty even starting a contraction. They can stand all day long waiting for that first step to occur. But when they initiate it, their movement usually occurs through the range of motion fairly good, even though they have difficulty with a certain rate of speed. Where our ataxic patient will have a lot of problems because they'll go so excessively fast through the range. They'll have problems with coordination. They can't cross midline at all, and most of that is the reason is they can't control their rotation in relationship to their abduction and adduction component, flexion extension also. So their rotation component is really lacked. It's the cement that holds together movement. Where the Parkinson patient has excessive rotation, they can't let go of it. They can't control it by letting go of it. So one doesn't have controlled mobility, the other one doesn't have controlled stability. Okay? As I mentioned, both of them have difficulty crossing midline, and that has a lot to do with that. And so a lot of emphasis on patterns crossing midline and being able to accomplish each one of those areas. Both patients have difficulty reversing directions. An ataxic patient will go to the end of range and come back very quickly, and a lot of times, like Bev was talking with the man with the shaver, would hit everywhere, because in reversing directions they don't have that control of going to one end to the other. Where the ataxic patients, a lot of times, they may get down to the food, but then they've got to wait a long time before they can get that food back to their mouth. Or they'll be walking in a straight line, and then they have a lot of difficulty in shifting that direction. So our emphasis is going to be different in treating them. The ataxic patient, we're going to work much more with controlled reversing of direction and being able to control that rotation component. Where the Parkinson patient, we're going to try to teach them how to move it in rhythmic initiation and how to move it a little bit quicker and to improve their rhythm in those areas. The ataxic patient has intention tremor, which means during the time they do something they have tremor, where the Parkinson patient usually has non-intention tremor. I knew a Parkinson patient once that was a surgeon who could still perform surgery in his later years, because during the time when he was doing the movement, he could be able to not have tremor, but it took him a long time to do it. Both of them usually has respiratory control problems. They both need to be worked with in respiration. Ataxic, again, being able to control their respiration. Parkinson being able to perform it, to be able to do full, complete movement, and to allow it to reinforce their movement. They both have weakness in extension. The ataxic, particularly in their ability to hyperextend their lower extremity. The Parkinson patient being able to extend and to get into an extended position where they can start using the reversal of antagonists, where they can go to the end of range of motion and come back in a smooth and coordinated contraction in the other direction. And both have problems with eccentric control, so we'd want to use combination of isotonics trying to help train them. And the last one is that with the ataxic patient, they very frequently walk with their toes in the air in a walking gait. And it's very important, and they're always back on their heels, so they tend to fall backwards a lot. So we work a lot with them learning how to grip their toes, how to use that in various weight-bearing positions so that they can get their weight over the center of their foot, which a lot of times helps to get contraction through the trunk, and then that helps to set up purposeful movements with the extremities.
Okay, thank you. Let's talk next about the patient who exhibits spasticity. That is such a major concern to therapists that we'd like to hear from both of you on this one. Bev, do you want to start us off?
Sure. I think perhaps one of the key concepts for me working with a spastic patient is to use rotation, because I think rotation is a key to unlock the spasticity. And so putting together combinations that would help increase the rotation so that the patient would be able to reverse movement, which would be a goal for the spastic patient. And for example, the unilateral patterns do have the component of rotation, diagonal one, but it's maybe not enough rotation for the hemiplegic patient. And they might be tight, might bump into spasticity and not be able to complete the pattern. So they would need to, for sure, use a bilateral asymmetric pattern, coming down and grabbing hold and bringing the arm up and across and getting the influence of the head, neck, and trunk rotation to help facilitate more rotation in the limbs and help to reduce that spasticity. And I think the other key concept for me with spastic patients is that of proximal stability. So often there's an imbalance proximally that will affect and increase the tone distally. And I think one of the key things for loosening up a tight hand is to be able to loosen up the tight shoulder and balance it out and give it some strength. And so one of the things that I found very helpful is resisting the scapular patterns using resisting the scapula in the chopping and lifting patterns, combining the rotation and reinforcing it with resistance for those patients.
All right, Greg.
There's so many things that we can actually use to approach spasticity with, and I'll just mention a couple more on top of what Bev has mentioned. First of all, positioning is so important. A lot of times you can just change the position of a patient and get their tone to be reduced or their associated reactions to be diminished. When you've got that, then you can start teaching them purposeful motions in those positions. As they learn that, and against resistance is a perfect way to do it because they learn so much quicker as long as you don't get any associated movement or abnormal tone. And as they learn that, then you can start changing their postures to more complex or more complicated postures. So we break it down into simple motions. If it's an extremity that has a lot of spasticity, we may start with a scapula first, and as the scapula develops an ability to decrease tone and get purposeful movement in it, then we may move to the upper extremity. Always starting with the good side first, or the least involved side first, going to the other side on top of it. And then of course ice is a great adjunct. A lot of times just using prolonged ice over a spastic muscle can decrease that tone long enough for us to really be able to start doing some re-education with them.
Spasticity was a problem for the patient, Frank. Let's take a look now at a videotape segment that shows some of Frank's treatment. As we watch, we will ask both Greg and Bev to tell us what we're seeing.
Well, this is Frank, and I'm just beginning to ask him to do some, we're going to check out his arm and do some passive range of motion. And just watch the effect of his trunk when I do the range of motion. He does have some tightness in the shoulder, but what I noticed as I was lifting his arm up, that not only was there tightness in the shoulder, but he really didn't want to shift his weight over towards that side. His head was down, he was a little more flexed, and most of the weight was over to the other side. So I asked him to look up and to follow his hand. And now we're looking at the diagonal one pattern as he's coming up and across his body. And again, the head and neck was not really following. So we began to wonder if there was some tightness in head and neck rotation or not. And now looking at the spasticity which was present in the elbow, and of course in the in pronation and wrist flexors and in finger flexors. And we're beginning with taking a look in a stable posture with Frank in prone on elbows and using weight bearing to help inhibit the spasticity as well as to develop some proximal stability. And just taking a look at his shoulder range of, his head and neck range of motion in rotation and also in the diagonal patterns. And you can see how much he rotates towards the unaffected side and how there's a little limitation on the affected side.
The use of the head and eyes is very important for somebody to learn weight shift, and you can see that Frank has some difficulty in being able to completely weight shift bilaterally by rotating his head. And it's a good beginning for us a lot of times in being able to assist them.
That was a little better that time in just repeating the movement. And so here we're just going to begin to develop some stability and use the technique of rhythmic stabilization to develop a little more control in that posture. And it could do rhythmic stabilization here on head and neck as well as on the shoulder girdle, and gave Frank the cue to look up while he was being stabilized to help reinforce head and neck extension. Now in all fours, this was the position, I believe, that the fellow who called in wanted to know why we were working on the blocks. And we did start here and began to do some stabilization, first on one side of the trunk, using both scapula and pelvis on contralateral sides to give more balanced input to the trunk, and then not giving him just one side, but also doing both sides to give balanced input. And began with a stabilization, then proceeded to rocking and resisted rocking. And it was during that time I didn't think I'd be able to go any further because the hand had a lot of spasticity, and as with the wrist. And began to see the wrist loosen up so that I could put his hand flat on the mat, as we, I believe, we'll see here. And right now, just having him, that's right, be able to get some control with the hand now in a fully extended position, and seeing if he can just shift his weight, doing some walking forwards and backwards on knees, and still control the weight-bearing function on the affected arm. And then I thought I'd try surface contact activity and just see how he could do. He seemed to be doing so well. And giving him a light touch to begin as he went up and pulling back. And the spasticity began to come in quickly. You can see in the hand it's flexing up. So perhaps he wasn't ready yet for a surface contact activity and still needed some more time in weight bearing. I thought maybe I would try and just see how the effect would be in the other diagonal pattern, diagonal 2, down and across and up and out. And here's Frank working on rolling again, putting two hands in contact this time, and so that I can emphasize the scapula, also giving some resistance in the diagonal 1 extension pattern, chopping down to the left, and doing some repeated contractions, trying to reinforce some head and neck and trunk flexion, and then reversing the movement into the reverse of the chop, the anterior elevation of the pelvis. And this segment shows using the same combination for lifting, giving some emphasis on scapula. And very often after, you don't need to do this technique with a great deal of repetition. Usually 2 or 3 times with resistance is sufficient to see some more balanced input into that area, where it's a heavy work activity. Again, doing some repeated contractions to facilitate an increase of range in the affected arm. And finishing up with some rhythmic rotation, which you have already seen, just to get some further range of motion in the shoulder. Frank has made some significant progress since this tape was, since the videotape, and he's now actively, when we made the tape, he was only able to raise his arm up to about 70 degrees with shoulder flexion, and now he can raise his arm overhead. It has a lot more increased strength in the shoulder girdle. And just in sitting, wanted to take a look at the hand now that we had put in some inhibition and stabilization to the arm. Wanted to just take a look at the hand, and he did balance himself spontaneously, trying to weight bear with that arm, which I was glad to see. having him just push into my hand, getting some approximation, doing some rhythmic stabilization, and then some repeated stretch for the extension. And you can see that there is a little bit of active extension coming in on the ulnar side. Finishing up with an evaluation just to see if there are any changes in the trunk and in the patterns. And this is something you can do after each treatment just to see if your input has made a difference. We don't have an initial segment to compare this to, but one of the things that I noticed with Frank is that the range of motion moved smoother, it moved more rhythmically as he was going through the patterns, and the weight shift and the position of his head, neck, and trunk had greatly improved. And you can see how much more he's able to shift his weight over to the affected side and incorporate the head, neck, and trunk extension with rotation.
What about patients with pain? They, of course, tend to protect the painful areas by avoiding movement. Bev, what can PNF do for them?
I believe, as we said in the question and answer period, the value of the PNF technique with these patients is using the indirect approach. And so often you have a patient with a painful shoulder who won't let you touch it, and what can you really do for them, where to begin? And so this, using the indirect approach, leading from strength, using other parts of the body to get some irradiation to the painful area to help inhibit some of the splinting that occurs around that joint and begin to put in a more balanced input and increased range and contraction in that area. I think it's been very valuable.
Okay. Francis is a patient with pain, and we do have a tape of Bev treating him. Bev, what would you like to highlight for us first?
Just that Francis had a shoulder pain because of the brachial plexus injury, and in this segment you're just going to see the result of just working with the lower extremity, lower trunk, lower extremities to get some influence in the shoulder and using that indirect approach before we proceeded to going more directly.
All right then, let's watch.
Francis is now positioned in supine where his shoulder and scapula can be fully supported. I'm going to begin working with the stronger inferior region to influence the shoulder area. So I'm going to start with lower trunk rotation, and Francis, I'd just like you to move your knees towards the other side. That's it. And then bring them back to me. That's it. And it looks like your towel kind of slipped out here. Let me push it back up. Okay. And bring your knees to me. That's it.
Now, an important thing to watch here is Beverly is working with Francis is how does the rest of the trunk have to adjust and associate itself while he's doing lower trunk rotation, and actually notice what that right shoulder is going through. And Francis isn't actually aware of the movement that it's going through to a large degree. So as an indirect technique, a lot of times we get results that we can't if we go approach the area of pain directly.
Get him all the way down to that mat and hold it there. And now push him back to me. Push him back to me. That's it. Another activity we can do to emphasize more weight bearing on the right side would be to ask Francis to lift your hips up, and I'm going to put a block right on your belt. I want you to knock it over to the right. That's it. Just rotating slowly as he comes up. Go ahead. Up and over to the right. Good. A little slower. Up and over to the right. Good. And again. Up and over to the right. And relax. Okay. Throughout the treatment with the patient who has pain, breathing is an important activity to continue. So we're going to just emphasize that with some manual contacts on the lateral chest walls. And Francis, I'd just like you to take a breath and blow it all out. I'm just going to follow him through first. And then, that's it, blow it all out now. Good. Okay, and breathe in. And I'm just following him through this time. And now blow it all out. Good. It's only after the indirect approach that we would begin to move more directly and actually put our manual contacts right on the painful limb. We're going to start by doing active range of motion with Frances in the diagonal patterns. I'm going to start with diagonal 1, and so Frances, I just want you to close your hand, turn it, and pull it up and across as far as you can. That's it. Up and across. Reach right over to the edge of the mat there if you can. Okay, that's good. Now open your hand up. Open your hand up. Turn it away from you and pushing it down and out to the side. All the way down. Good. Now close your hand again. Turn it, pull it up and across. Watching your hand real nicely, following with the head and neck. Good. And hold it there. Now, open your hand up. Turn it away from you. Open it up. No, open it up wide. That's it. Turn it away from you. Push it down now. Push it down. Good. Frances, we've completed the treatment session. Let's take a look and see how your patterns look now. So let's put your right arm out to the side. That's it. And grab the top of the wrist. Now close your hand and turn your fingers in towards you and bring it up and across your face as much as you can. That's it. And now open your hand, turn it away, and push it back down and way out to your side. That's good. Okay, now bring your right hand across to your opposite leg and come underneath your wrist this time. For the lifting pattern, I want you to open your hand and turn it away, turn it towards you. Now lift it up and out to the side as far as you can. Good. Now close your hand and turn it and bring in, touch that thumb to your leg. Down and across. Good.
Greg, you'd care to make a comment?
Well, first of all, on this film that we just saw, Frances, during the time of the demonstration that Bev did on him, didn't really significantly increase his range of motion, but he had a decrease in symptoms. And so that can be an aspect of it. So in evaluating somebody, don't just look at your range of motion, but also have a subjective evaluation that you can grade that on, as we did with him. As far as some other things with pain, Maggie used to be just brilliant at being able to find indirect ways to treat people, and some of the results that we used to see that she'd do were just amazing. We saw her take a frozen shoulder patient one time and do nothing but lower trunk patterns, but direct it so every time she did a pattern that the movement would occur at that painful shoulder, and she got about a 30 to 40 degree increased range of motion, which nobody else had ever done, and many other different ways that she would approach it. So it takes creative thinking a lot of times when you go to indirect, because you keep your hands off at the painful area. But ice is very effective to be using in the area, and reinforcing everything with breathing so the person relaxes, because you don't want them to be holding themselves tense. And of course, you don't want to do anything that increases pain. You want to start getting movement in that area of pain, but you don't want to push it. You want to really stay indirect. You'll be amazed if you keep yourself away from going into the area of pain, how frequently you can decrease it faster by doing an indirect approach. And I just encourage everybody listening to this to give it a try.
Okay, and Bev is nodding agreement, I see. Okay. Finally, let's look at patients with spinal cord injuries. They represent such a wide range of abilities and disabilities, but nevertheless, are there some key concepts for PNF techniques for these patients, Greg?
Well, I think PNF fits in so well with spinal cord injuries. It's a wonderful system because, as we know, spinal cord injuries vary from those that are low paras all the way to the high quads. And so the approach to them varies depending upon the level of injury and the degree of spasticity and the various other aspects that we've got. But the underlying need of a paraplegic or a quadriplegic patient is to increase strength and being able to improve their mobility so that they've got good strength, good endurance, and they've got an ability to respond quickly for their movements. And so a lot of what we do with PNF is really work with strengthening and endurance. Somebody, I would want to take them to almost fatigue, as long as it didn't increase any spasticity, to strengthen them and to work with them. A lot of work on breathing with your quadriplegic patients, and everything has to be geared towards function. A lot of sliding board activity and other kind of work here. And so I think those are some of the important things, and use of the diagonal patterns and trunk patterns are just inherent to the rehab.
Okay, we have already met the patient George on tape, and we'd like to look at him once again now. As you've heard, George is a C5-6 quadriplegic, and we'll be seeing Greg working with him to facilitate his ability to roll. Let's watch.
Now let's move right on into doing some rolling activity with him. Because he's got some strong biceps, I'm actually going to use the biceps to help reinforce it. And I'm going to get him to just begin at this point. And George, let's see if you can actually roll yourself over. Can you initiate that at all? Okay, well, he gets his shoulder girdle up and off. Now let's actually cross his legs and see if he can do it with his legs crossed. Let's see if you can roll now at this point. Okay, and I'll go ahead and give assistance, and let's see how far actually he can go. So he gets up and over with moderate assistance as he goes into rolling. So now at this point, what I'm going to begin with is checking with the scapular patterns, the integrating upper extremity patterns in it, trying to find patterns that are strong and muscles that are strong that I can help to reinforce that may be able to assist him in getting more independent in his rolling activities. Okay, now let's check another pattern, see how he's able to function with the shoulder girdle pattern of anterior elevation. Pull up. Good. Pull up again and relax. When I say good, it kind of means you can kind of let go at that point. Pull up. Beautiful. Pull up. Beautiful. So I'm going to first begin with just scapula anterior depression. Pull down on your shoulder girdle. Let's just have you down to here. Now keep it down here. Don't let me pull you up. And pull down again. And this is a very weak pattern, so I'm going to go ahead and bring it down in this point. Keep it down here. And pull again. Good. Keep it down here. And pull down again. So I'm going to bring in the biceps, which I know are fairly strong, to assist me in it. Try to keep your elbow right down here. Bend your elbow. That's it. There we go. Now we're getting the scapula to come in. Pull again, George. That's it. Pull again. Much stronger. That's good. Pull again. So I'm using irradiation now to assist us in facilitating what he can in post-anterior depression, seeing if we can even get it stronger. Pull it down. Beautiful. Pull it down. Now keep it down here and don't let me pull it up. That's it. Come on. Pull it down there again. Great. Now let's see what he can do. See if we've made any gains in his ability to do it independently. Let me bring it back. Now pull it down. Oh, that's stronger. Pull again. Yes, sir. Pull again. I'm even going to add his head to it this time and get his head involved. Keep your head down here and don't let me pull you back. That's it. Now pull that arm down again. Good. Pull that shoulder girdle down. Good. And pull it down again. Excellent. And relax. Let's actually just take and see how much he can actually use this shoulder girdle to roll. Pull up. Look at that. That brings in, and you can actually see the pelvis starts to come in the minute we get that resistance and that irradiation in there. And relax. Come on back. A little bit further. Now roll. Pull that shoulder. That's it. Go. That's it, boy. Pull again. Good. Now let's go again and pull that arm, bend the elbow. Pull it up. Beautiful. Pull it up. Hold it here. Don't let me pull you back. You got it? Now I'm getting biceps in. I'm trying to see if there's any wrist flexion. There's not. I'm going to bring it back as much as I can and let go. Now let's see if you can pull that arm up and across and roll. Pull it up and across and roll. That's great. Now let's roll you back even a little bit further. Now go again. Pull up and roll. Beautiful. Now do it again. Let's go. There you go. Now let's actually bring you back onto your back and let's see if you can't do that yourself. Go. Go. You got her. That's it. Very good. All right.
We would like to show you just one more tape today. You've already seen the patient Evia several times, and we thought it would be good to take one last look at her. Greg, what would you like to flag for us as we watch this tape?
Well, first of all, Evia had a bilateral stroke. She'd had one a year previously, and she'd just come back into the rehab center with this one. She had a lot of apraxia. She had some spasticity. She had both aphasic... I've lost my train of thought. She was aphasic both as far as being able to receptive and expressive aphasic. And when we started getting into working with her, there were some real difficulties. We had some walking sections that we don't include here, but we've included the sitting, the before and the after. So I'd like them to watch the before sitting posture, what we do to facilitate her trunk, and then how she looks after we get done in her sitting posture and see if they can see some change.
All right, then, let's watch Greg with Evia.
Now, sitting on the edge of the mats, we can observe how Evia actually sits. Very similar to the way that she sits in her wheelchair. Once again, as part of treatment, what I want to do is to help stimulate her to get more bilateral weight bearing, to be able to start getting a much more upright spine that'll help to carry over to both her kinesthetic feedback and her ability to use the biomechanics for gait. We began first with Evia's least involved side, working with trunk, evaluating it, starting to do some treatment on it. Now we're going to evaluate her more involved side, trying to get ideas of how it compares and contrasts to the other side. I'm going to first begin with the pelvis. Evia, pull your pelvis up. Pull up. Don't roll. Back onto your side. There we go. Just your pelvis. Remember, pull it up. There we go. Now pull again. Good. And pull again. Hey, that's good. Pull again. And she's actually doing fairly well. The initiation of the motion on this side is fairly good, but as you can see, the one difference here is that she doesn't have the ability to segregate it from the upper trunk. So she's working them both together. So actually this would be a good opportunity for us to see if we can start putting the two of them together, to see if we can start teaching her how to be able to have independent motion of both. So let's see if we can now have her pull the pelvis up, and I've shifted my hand grip from pelvis and scapula. Now pull up. Good. Now she's doing pelvis real well. It's independent of the upper one. Pull again. Pull again. Pull again. Beautiful. Pull again. Let's get the pillow there. Pull again. The hand in a better position. Now let's see if she can actually start doing something with the scapula. Push it back and down. Push it. Good. Push it down. Beautiful. Push it down. Beautiful. Push it down. Now let's see if she can combine the two together. Do them both together, Evia. That's a girl. Pull them both together. Okay. Now relax. You are doing such a good job of them independent. I think you can do them both together, but don't try so hard. Keep it here and don't let me push them forwards. Keep it right where they're at. That's it. Now push back into my hands. Push. There. Good. Do it again. Good. Do it again. Now she's starting to do some reciprocation. Pull. That's it. Pull. And pull again. And pull again. Well, now that she's moving the pelvis so well, let's take it into lower trunk. Let's see how well she's actually able to use this pelvis and at the same time use her lower extremities. I'm not going to take the weak lower extremity by itself, so I'm going to put them together so that they can reinforce each other. So now let's see what she actually does at this point. We'll just start by bringing her back just a short way back and then having her pull up and roll onto her side. Good, Evia. Pull again and roll right up on your side. That's a girl. Well, now we've got Evia back up again and for a reevaluation. And I think just as a general overall evaluation of her, we can see that she's made some fairly good improvements in her sitting posture. Pelvis, she's now got equal weight bearing pretty much between the two sides. Her upper trunk is now, and scapulars are now sitting over the pelvis. Her head and neck is now in a better position, and she's not putting as much weight into her left upper extremity as she was to begin. So I think for an initial treatment, the facilitation that we did in the trunk has made some significant carryover to her functional position of sitting.
That's nice. Thanks to both of you. And thanks very much to our demonstration patients and models. We really appreciate all of their help. Now it's your turn to talk directly with Greg and Bev. Shall we take the first question?
Sure.
Okay, let's go to our studio audience. Hi, go ahead.
Hi. This is for either Bev or Greg. Greg, you mentioned that Evia was apraxic, among other things. Do either of you notice any effect on praxis from the PNF patterns that you do with the patients?
Do you want to take that?
Sure. I think what I've seen is that the effect of resistance can help reinforce a motor performance. And for example, one of the, I just like to demonstrate on Greg, for example. If I've seen this with patients who are like trying to get down to maybe their foot and not sure how to reach down, where to go. And so what I can do often is to just resist the head and neck and trunk pattern. And I'm going to just have you reach down for your right shoe there. Go ahead and reach down for that shoe and hold it there. And now look up over your other shoulder and sit up and hold it. That's it. And just by putting in some resistance to the pattern, it helps give them some more kinesthetic awareness of where to go, and oftentimes they're able to follow through voluntarily with that. So I think that's been something I've seen as valuable.
Thank you.
Let's take a phone call. Hello, you're on the air. Where are you calling from?
I'm calling from Minneapolis, Minnesota.
Welcome to the video conference. Go ahead.
Okay, my question is for Bev. I'd like her to please clarify the rhythmic stabilization technique that she demonstrated with Frank by describing what direction the resistance or pressure she was giving with her hands.
Sure, be happy to. I'm going to just demonstrate on you again. Okay. On rhythmic stabilization, we're resisting rotation. And so essentially, if I was going to do rhythmic stabilization on shoulders, I would, let me just move you, Greg, so I can show them what I'm doing. I would just be pulling back with one hand and pushing forward with the other, and then reversing. So I'm really thinking of diagonal patterns in the trunk and resisting rotation of the trunk. So when I put it together, it would look like so, and hold it so that I can see the trunk coming into play. And as I change my voice commands and I say, and hold, that's when I shift direction, and hold, for changing the resistance to the opposite rotation. Okay?
Okay, thanks. Let's take another call. Hello, you're on the air. Where are you calling from?
St. Joseph's Rehabilitation Center in Albuquerque, New Mexico.
Welcome to the video conference. Go ahead.
Is there any benefit in doing passive range of motion to a flaccid arm in diagonal patterns? And how can this be enhanced to increase tone?
Would like to deal with that.
Sure.
Okay.
Be happy to. I really think there is, because again, you can get that component of rotation. And one of the ways with a flaccid patient that I will change my manual context is to put one hand on the scapula and one hand on the wrist, and to get their head and neck following the movement to increase that rotation and reversal of direction, reinforcing it with a total pattern such as rolling, and switching my manual context to flexor and extensor surfaces to give some input to both muscle groups, rather than keeping them both on the extensor surface, as I might do with a patient who has flexor spasticity, and I wouldn't want to give any more tactile input to the flexor side.
Okay, Greg, you'd like to add?
Yeah, I'd like to at least put a precaution there, because you need to be careful. We know that the shoulder range of motion is inherent, and it's apparent that the scapula has to be included in the shoulder range of motion. So if you're doing passive range of motion and you're not including your scapula in it, you very well could impinge those shoulder structures and develop a painful shoulder. In fact, I think that a lot of the painful shoulders that we see in the hemiplegic patient are directly related to aggressive passive range of motion.
Okay, let's take another question from our studio audience. Hi, go ahead.
Hi. I would like to ask, have you found these techniques beneficial in working with healed fractures, such as a comminuted fracture of the humerus, especially in older patients?
Oh, great. I think that's a great question, because being in orthopedics more now, it's something that we see. And as far as being able to treat someone who has a fracture, I'd want to be able to start right away out, do an indirect approach to get irradiation to the area. So let's say that we do have somebody with a fractured hip. I might start out very early on doing work on the other leg. And we know the irradiation patterns occur in the reinforcement to the opposite side. I'd go to upper trunk, work on the ankle and foot. And we'll see that these individuals will appear to heal faster, which is something we don't have any direct research on to prove. But we also know that there's a much greater functional abilities that they have when they can start back into weight bearing, because they've got those muscles working, they've maintained some of the strength around those areas, and I think it's real valuable, and it's something that I use a lot.
Okay, thank you.
You're welcome.
Okay, let's take another phone question. Hello, you're on the air. Where are you calling from?
Hi, I'm Evelyn Water from St. Mary Medical Center in Long Beach, California.
Welcome to the video conference. Go ahead.
Thank you. Can you use facilitation such as vibration with PNF?
I'll be glad to take that. The way I look at it is that PNF is a group of tools. What we're trying to present to you this weekend, during this day, are some tools. And those tools can be integrated with anything that would be functional. So vibration, any of the Bobath approaches, Brunstrom approaches, any approach could be integrated into PNF. I don't think that it's a system that has to stand by itself. The tools are applicable. I just so strongly emphasize the use of the diagonal patterns and the use of appropriate resistance as a means to approach patients. And if you need to use vibration or brushing or quick eyes to further facilitate a muscle, then I'd say that's a very good approach to use. It's something that I use in my personal practice.
Okay, another phone question. Hello, you're on the air. Where are you calling from?
Norfolk, Virginia.
Welcome to the video conference. Go ahead.
Yes, my question is directed to Greg, and it is, do you have a specific treatment protocol for addressing genu recurvatum in the stroke patient during gait?
Yes, that's a good question. In fact, we regret that we haven't had a chance to really cover gait to a great degree today. But as far as genu recurvatum goes, we know that it's a major problem. And a lot of times it depends upon where it's coming from. Sometimes it's related to tight gastroc soleus. Other time it's related to problems in trunk control, hip control. So very frequently we want to work on improving range of motion and being able to improve sequencing of motion. A lot of times when you get that pelvis and the lower extremity functioning in a coordinated fashion, the person when they stand up have much better control of that recurvatum. If they have a tight soleus, we know that the soleus is one of the primary knee extensors. And so in a weight-bearing position. So you want to be able to get that soleus so that it's lengthened so that you can have full range of motion there. But if it continues, we've even found that putting a slight heel lift on there, a temporary heel lift to allow better weight bearing through that heel, helps to keep that knee from snapping back. Biomechanically, it's very difficult with a heel to snap your knee back. Try it when you're in high heels. You can't do it. So use of a heel lift, stretching of the soleus primarily, training coordination patterns between gastroc soleus, between quads and hamstrings, and particularly at the hip, pelvis, and lower trunk areas, all seem to be very effective at being able to assist someone to then get up in gait and go through resistive gait activities to help train them how to be able to maintain a more neutral position of that knee during gait activities.
Okay,
Does that
thanks.
help?
Yep. Let's go back to our studio audience for a question. Hi, go ahead.
Hi, this is for Bev. We saw Greg demonstrate the treatment of PT in a quadriplegic. How would you, from an OT perspective, treat a quadriplegic patient?
Good question. I think there is a lot of use of resisting the diagonal patterns that we can use and apply to functional activities. And one of the things that the patient needs to be able to do first in order to perform functional activities in the chair is to be able to stabilize himself and get that arm back on the handlebar. And so you can use a PNF diagonal to do that. And if I can demonstrate on you again, Greg.
Of course.
I just want to perhaps put my hand back here on the posterior scapula and coming down and across in D2 extension to facilitate coming back into D2 flexion with elbows flexed to get back onto that handlebar. So I could use repeated contractions to do that and just have him, you would probably be back in your chair in terms of being a quad having that much sitting balance, we wouldn't need to do this. Okay, so that just looking down at your hand and now look back and pull your arm back and hold it there and then do some repeated contractions. Now pull that back some more, get it back some more and hook it around that handlebar and relax. So you can use that to build strength. Another thing I found that quads, in order to do functional activities such as reaching down to release or empty their catheter, are often afraid to bring their selves forward because they don't have enough confidence that they're going to be able to get back up. And of course, hooking their hand on the handlebar helps, but still they can be weak in that extension with the head, neck, and trunk. So one thing I might do is to, if Greg can get his arm back here as if it was on the handlebar, would then be able to work on strengthening up this pattern by beginning with some stabilization. Let's just put your hand on this armrest, for example, and just starting in a mid-range where he's not too far off the back of the chair, doing some rhythmic stabilization here, and then having Greg do some rocking just in this mid-range position to lean forward and now look up over your shoulder and go back and hold it there. That's it. And come forward again and look up over your shoulder and hold it there. So to begin to develop some head, neck, and trunk extension in that range, and then would be able to follow through by reaching all the way down to the catheter and have some more strength built in to be able to return and come back up to sitting. Another application might be to, in dressing, how the C5-6 quad often has trouble bringing their shirt and lifting it up over their head, not enough shoulder flexion. So one way we might do that is to seek reinforcement with the strong head and neck muscles, and again using the diagonal 2 pattern for getting the clothing over the head. I might put together this combination, such as putting the hand on the head, and I just want you to look back up to me, Greg, and lift your arm up and hold it there. Getting my head locked in and reinforcing with that, and then repeating on the hand. Hold. Okay, let's try again. Let go. Okay. All right. Talk too long. Okay. Look up to me and hold it there. Now push that arm up some more. Get that arm back some more, and hold it there. And then he would be able to follow through by trying to lift the shirt up over his head. So being able to put some combinations together like that.
Okay, thank you. Let's take another phone call. Hello, you're on the air. Where are you calling from?
I'm calling from Harmerville Rehabilitation Center in Pittsburgh, Pennsylvania.
Welcome to the video conference. Go ahead.
Are PNF exercises effective with learning disabled, CP, or Down syndrome children who have gross and or fine motor problems?
Greg, would you like to at least begin that?
Yeah, I would like to begin on that. A lot of this began when I started working with some developmentally disabled children, both who are mentally and physically disabled. Some of the work that had stimulated me to use PNF was the work of Moshe Feldenkrais, in which he had done a lot of work saying that as a person learns to move and improve their movement, they also have an improved ability to think. And we didn't do a research study on it, but my clinical observation was among these 5 or 6 children that I spent about a month working with twice a week, that we really got some significant improvements, both in their ability to function, to run, to perform normal activities. Going back to basics such as crawling was so important because many of them had skipped the crawling, and we got in and resisting crawling and improving that ability. Rolling, they had a lot of inability to combine their upper and lower trunks together. And so as we did that, they started to really improve in their functional level, and each one of them, their teachers were saying, seemed to be improving in their schoolwork. So I think that there is a real place for this in this area, as well as with the healthy populace. I think we could do a lot to evaluate them as well.
Okay, Bev, something you'd like to add?
Yes, I think that PNF has a contribution to make also to the sensory integrative approach to the patient. And just for an example, with the learning disabled child who has trouble crossing the midline, the PNF diagonals have a great deal of application. And even using the bilateral asymmetric combinations of chopping and lifting, bring both sides of the body together. And working with children in the school for a period of time who are in a learning disabled program, and had them practice like doing chalkboard writing, using the chopping and lifting patterns and getting some more control in the head, neck, and trunk, seemed to improve the interaction between the two body sides for them.
Okay, thank you. That, I am afraid, does it for questions because we are just about out of time. Thank you for all of the ones that you asked. It is always good when you participate because that's really what makes a video conference come alive. Bev, any final thoughts before we close?
Well, I'd just like to say that the video conference we presented quite an overview of PNF, and to really learn the techniques and be able to use them well with a patient, that would really encourage the people to participate in continuing education course. Offer a 2-week course for occupational and physical therapists, and I know Greg has a series of courses that he offers as well.
Okay, Greg?
Well, I'd just like to once again reemphasize to everybody who's watched this that they can take the tools that they've got or that they've learned here and start practicing, maybe first on each other, but then on patients, and seeing what kind of results that they can get there. And you don't have to know the patterns to be effective at using some of the tools. All of the techniques are things that do not have to be done in pattern. Although it's more effective, it doesn't have to be done in pattern, and you can do it with cardinal plane motions. You can, but use your appropriate resistance. Start learning how to use your manual contacts and your skill of resistance to be able to really facilitate someone to an improvement.
Thanks so much to both of you for sharing your experience and your expertise with us today. You gave us a lot of good information, and we appreciate it. Okay. And thank you for watching and participating. We ask you to do one last thing before you leave. Please take just a minute to complete the evaluation form. The Aaron staff welcomes your comments and values your feedback. While today's program concludes a full season of quality educational programming by Aaron and its sister company, Executive Communications, plans are well underway for the 1987-88 season, which begins in September. Now, the schedule for next season is in your workbook on page 19. You will see that Aaron and Executive Communications have created a series of 20 educational events. The programming has been expanded to include 4 general nursing topics as well as rehabilitation subjects and the Management Vision series for administrators and managers. Now, you may remember and may in fact have taken part in an extensive survey earlier this year about video conference programming. Many respondents indicated that they would like the programs to be shorter and to be positioned between the intermediate and advanced levels. Your feedback was heard and will be heeded in all 20 programs scheduled for next season. They will be 2 and 3 hours long. They'll also be delivered at higher content levels and targeted to individual treatment disciplines, including physical therapy, occupational therapy, and nursing. Administrative and management programming will continue to be available through the Executive Communications Management Vision series. We hope you'll join us. If you would like to subscribe, or if you would like further information, including a preview videotape of the season, please call Aaron toll-free at 1-800-331-5190. That's 1-800-331-5190. In Pennsylvania, call area 412, number 967-AREN, 412-967-AARON. All of us associated with Aaron wish you a relaxing, safe, and healthful summer. We'll see you in September.